All right, I hope everyone had a good break. We are going to go ahead and get started with our next section. So our next section, we will be talking about the fourth trimester project, which for the IMPLICIT network, this is kind of our newest endeavor. And we are entering phase 2. So Carolyn, if you would like to, next slide. So before we review this, I just want to let everyone know that this will be more of an overview. We will be looking at some overall data, but this month, at the end of the month on April 30th, we will have a specific fourth trimester webinar to go over our phase 1 data and to hear from different sites who have implemented their challenges and what they've done and their workflows. So just to review what our fourth trimester care model, our aims of it are to identify patients at risk, have an early postpartum visit, and establish a care team. Next slide, please. So the core components of fourth trimester model for our network are very similar to ICC. So IRB approval is required. Again, this is a quality improvement project, so most likely you should be exempt or receive exemption status. And then a prenatal patient registry is to be created. So this is how we create our study IDs and track the patients. It is a little bit more complicated than ICC. With ICC, it's pretty easy we create the study ID based off of the child. But for the prenatal patient registry, it really depends on your site and how your site is set up. How, if you have residents, what patients they see for prenatal appointments and who they may deliver. So this is something that we are happy to work with sites on and use some of the experiences of our other sites. And yes, this is a separate IRB from ICC. So for the fourth trimester model, we have 3 screening periods. One is in the 3rd trimester around the 36-week visit. One is at hospital discharge after delivery. And then one is at the early postpartum visit. And our early postpartum visit, we would like to happen within 3 weeks of delivery. So those are our 3 unique screening times that we're screening with our fourth trimester questionnaires. But then part of our fourth trimester model also wants to make sure that not only are we bringing patients in for an early postpartum visit, but we are also making sure that they still attend a traditional postpartum visit, which is more of that comprehensive visit. Patient attendance tracking is important with this project because, as we know, with any new project, screening may be a little light at first and getting providers used to that workflow. So one of the major things we want to see is how are we doing at bringing patients in earlier. So making sure we have an ability to track that outside of just the questionnaires. And then working on getting data into REDCap. Similar to ICC, the data is all de-identified, and we have the system set up in REDCap to collect that data. Next slide. So this is what that fourth trimester care model looks like. So the 3rd trimester visit around 36 weeks, really that screening for our fourth trimester model is to identify any pre-existing conditions or possible risk factors to help start creating a plan for postpartum and to just make sure that the services that the birthing person needs are in place. Our hospital discharge screening occurs normally 2 to 3 days from birth. And it's to really help us identify any delivery or recovery complications that have occurred, identify any possible impacts to the baby, and then also making sure that our patient is set up with the appropriate care team members. So whether that's lactation support, or if they need consultation with like cardiology or anything like that. And then having those appointments set up and ready to go for the early postpartum and the comprehensive. The early postpartum visit is within 21 days from birth. And this comes from the ACOG recommendation that came out in 2018. And this visit is really, we know that a lot of complications occur sooner than that traditional postpartum visit. So really wanting to make sure we get these birthing people in sooner and have a point of contact. This screening is, we're assessing biomedical and psychosocial conditions, following up on some of the identities for the postpartum plan. So whether that was contraception or feeding methods, making sure the patient is connected to the support services they need. Not all of our sites, but many of our sites are using this as a dyad visit with the 2-week weight check visit. So they're able to bring in both baby and the birthing person to try to reduce any additional need for extra visits, because we know during this time there's lots of visits for the baby, and the birthing person may feel overwhelmed if having to add another visit. Some of our sites also use this as a telemed visit. And then the routine postpartum visit around 6 to 8 weeks after birth. So this is really, your normal standard of care that you're already doing. We do have the ability to do a second postpartum screening if sites desire, just to see how we are doing. But this is kind of our care model in a nutshell. Next slide, please. So this is just a timeline of kind of how this project has progressed. So this was started being talked about in 2018 after the ACOG recommendation came out, and it has been a lot of work kind of getting to this point. Some of the biggest work recently has been around updating our questionnaires and kind of rolling this out so sites are able to start implementing. Next slide, please. So what are our phase 2 updates? So when we talk about phases, it's similar to ICC, and technically with ICC, we're in a phase 3 iteration, and a lot of that looks at how the questionnaires are filled out or what questionnaires we're using, if there's any major changes that can impact the data. So our pilot period is considered the period when sites did more chart reviews. And then our phase 1 period is when sites implemented the early postpartum visits and the first iteration of the questionnaires. So what we have done to move to phase 2 is we have revised the questionnaires. A lot of that has come from our initial use, provider feedback with that, identifying gaps we may have found. So updating language, expanding some of our questions like our substance use question and mood disorder question, both of which are a little more complicated than our ICC, but really I think our goal is to set our providers up for success with these screenings. And then adding sections such as adverse birth experience questions, both from the patient and the provider perspective. We have developed a code book and 4th trimester phase explanations, similar to ICC, so you can see where the questionnaire updates have happened and why we've made those updates. And then that code book helps with looking at what data points we need to upload into REDCap. We have, well, not we, Amy has been working on a national EPIC build for fourth trimester. So it will be very similar to ICC in being able to access a build and download it for your site. We have also begun work on scholarly publications around kind of our phase one implementation, pilot sites, and the data that we have collected thus far. We are now officially welcoming new sites if they're interested in doing fourth trimester, to please reach out. Next slide, please. So for the implementation process, first you'll reach out to me, let me know your interest, and we can set up some meetings. So similar to ICC, we would need to submit an IRB. Like ICC, we have the benefit of being a collaborative organization where we have IRBs that have already been created for other sites that can be used as templates to create your IRB. Creating a workflow for early postpartum visits. This is really important to identify how best to do this at your site and what resources are needed. And then also creating workflows for the screening questionnaires. Our goal with these screening questionnaires is to ideally have them built in as smoothly as possible to what's already happening at those visits. And these questionnaires aren't necessarily ones that the patient fills out directly, or not all the questions need to be asked directly to the patient. So those are all things we can work with you on, making sure that we're streamlining the process and trying not to interrupt how your standard of care is currently working. So the last thing would be building the questionnaires into the EHR. Next slide. So I'm going to let Amy jump in here to give a little bit of additional information on the fourth trimester EPIC build.
Can you guys hear me?
Yes.
Great. Like with the ICC build, we are working on an application for upload to National EPIC, so that anyone who wants to should be able to ask their site to download these specific data elements, and whichever build you would like to implement at your site, just like with ICC. Some places are doing this as smart forms, some places are doing this as notes. So finding out what would work best for your site and then having that implemented is an important piece of it. This will allow for easier integration with sites that use EPIC, so you can just copy what other sites have already done, and it will be available in the EPIC community library if it's approved. We are still in the application phase for this. Just like with ICC, though, this will also be added to the Google Drive. Can you go to the next slide, please, Anna? This is just an example of the smart form for those of you who've used EPIC, and some sites are using this for parts of their ICC build. And then next slide. For sites that don't have EPIC, many EMRs have similar functionality, and the build documents that will be uploaded to the Google Drive will also be useful to those sites as well, because even if they're not using EPIC, a lot of sites use similar data binding techniques, so it will help whoever is putting it together for you to conceptualize what we are asking for in terms of prompts and scripting for questions. One of the differences between this and ICC build is that where this is actually going into the patient's chart rather than into the child's chart, there's a lot more data points that can be pulled directly from the chart without having to document them, like their gravida and parity. That is stored elsewhere, so we don't need to ask that question of our end users or providers, because we have that data elsewhere, and asking somebody to put it in another place is just busy work that we don't need to do. So there'll be a little extra piece of this that will not be included in the smart forms or notes unless you decide to do it that way. but as an end user myself, I would prefer not to do it that way. And of course, if anybody has any questions or would like me to discuss this with their data team or their build team, I'm happy to do so. That's all I had, Anna.
Thank you very much, Amy. We also are creating a fourth trimester toolkit similar to ICC that is in the works. We don't have a timeline on when that will be finished, but that will also be something to help with implementation. And we have a basically is a package where we can help walk you through implementation if interested. Before we jump into data, does anyone have any questions about any of this? Laura?
Ultimately, especially for Epic users, will it link to iPads so that the patients can fill in some of the information?
That would depend on how your site built it. That is certainly feasible with the way that the data is being presented. So if you're using a smart form to collect the data and you use iPads at the moment, that can be built, yes.
And that would be something that your site coordinator would help work with you on to help with that build process. Any other questions? All right. So again, we will be having a webinar April 30th. So right now, when we're going over the data, this is going to be a very high level overview of just kind of what our data we have so far. I will be presenting this. I'm definitely not Mike, but he is still on this call. So if we get through it and you have any questions, please ask him. Again, he will be doing the data portion during our webinar on April 30th. So if you have any specific data questions or things that you would like to see with this data, please reach out and let us know, and that will help us when we are creating the presentation for the webinar. Next slide. So this is just looking at the data we have to this point for phase 1. So we have data collected on just over 2,000 mom birthing persons. And you can see the breakdown by sites. I will give a caveat here of we have sites that are collecting data like UPMC Altoona and St. Margaret. And we have that data. We just have not gotten that data into REDCap yet. As with the beginning of any project, it is a little bit more tedious getting the data in than with ICC. And then we also have some sites that still have some outstanding data. But when we're looking at the next couple of slides, just keeping that in mind that it's data from these 2,000 birthing people. Next slide. So this is a breakdown of our data of the year and month of birth of the babies for those birthing people. So again, we try to include the N in these slides because screening data is only as good as the data we have filled in. So since this is a new project, we definitely have gaps in our data that we're aware of, but this kind of just shows you the breakdown of the number of, or where kind of our numbers of babies are coming from during what time frame. Next slide. So one of the great things about our screening is we have questions that repeat in multiple questionnaires. So one of those questions is our contraception question. We have it worded the exact same in the prenatal, hospital discharge, and well check. And the idea of this is being able to really track, you know, if a intention matches kind of what's happening postpartum. That being said, if you'll take a look at the ends and notice that they are varying degrees, our largest N is within the postpartum check, but that N also, our birthing people can have more than one postpartum screening due to some sites utilizing it both at the early visit and at the comprehensive visit. So this is just one example of how we can look at our data and see, you know, you can see for the no method at the top, we have a higher percentage within the prenatal and hospital discharge ends, but then that decreases when we get to the well check. So it's interesting to be able to compare these. This is not looking for at a 1-for-1, so we are not seeing here that these are the same patients that filled out the form. That is something that we will be able to look at, is if a birthing person has answered that question in all 3 forms, what did that look like? Did they plan to do a certain method like Depo and end up with that method, or did their plans change? Next slide. So the other question where we can do this is our feeding method question. This is one area where we discovered an issue when we rolled out our phase 1, is that we accidentally left this question out of our prenatal form. So this has been corrected with our phase 2 questionnaires. So moving forward, when sites implement the phase 2 questionnaires, we will be able to collect data for this for the prenatal period, hospital discharge, and well check. Again, looking at intention versus what actually happened, and the potential of being able to track, you know, what the feeding method is after birth, because we know it may start out with human or breastfeeding, but it may end up decreasing as the postpartum period continues. So we already have had some residents looking at this data. Fortunately, our Rochester site did not miss this question on their prenatal, so they do have data from all 3 of their visits. And this has been one of the areas we really have been looking at. Again, just making sure that you notate the difference in ends on this. Next slide. So one of our big screening questions is our biomedical risks. We're looking at biomedical risks, not just for this current pregnancy, but any previous pregnancies or any history of anything. So you can see at the top is our none category. And again, these slides will be handed out or sent to you all, so you can take a closer look at this. But you can kind of see where the screening falls. Our bigger categories being hypertension, preeclampsia history, gestational diabetes, and morbid obesity. So again, this is something that we can look at in the prenatal and the postpartum form. Next slide. So this is our intrapartum complication. So this question differs from the biomedical risk question. This is more looking at this current pregnancy, what happened around delivery, and then in the postpartum period. So you can see some of the questions or risks are the same. So like hypertension and preeclampsia towards the bottom there. But then we also are asking about some other things like bonding issues or breast complications. So to really better understand also things like shoulder dystocia, so to understand how that current pregnancy's delivery went, and what things should we be looking out for. Next slide. So this is one of the biggest things we have been tracking is our early postpartum visit, really wanting to increase this and start this at some sites outside of having just the comprehensive visit. So you can see we almost have 50% of our patients coming in within 3 weeks. I believe it is 49.5%. So those first two columns. And then we still have patients that have no visit, that 35%. So really wanting to not only bring patients in for an early postpartum, but also making sure that they are attending a traditional postpartum. And then the fourth column, the 6.8%, that is missing documentation. We know that they had a visit, we just don't know when that visit occurred. Next slide. So the next couple of slides are looking at some of our biomedical interpartum risks and comparing those to the early postpartum visits. So the further to the left of the table is the earlier the visit. So the first two columns are within 3 weeks, and then the middle column is greater than 3 weeks. So the darker the number, the better, the more amount of, the darker the number, that means a higher percentage of people who screen positive for that risk attended a visit during that time period. So I do not have the ends here, but we do have the ends from the other tables that we can look. So we can look at what was the N for the history of DVT-PE. Out of that N, 100% of those patients who screened positive for it had a early postpartum visit within 3 weeks. Next slide. So this is looking at intrapartum complications. So again, you know, we really want to see those darker numbers appearing towards the left of the table. But you can see kind of, we really are interested in having these early postpartum visits, but also, are we bringing people in who are at risk for these early postpartum visits and making sure that they're being seen. Next slide. And then this one is symptom since delivery. This one you will notice on the right, we have 0 for the no postpartum visit. That is because we screen the symptoms since delivery during the early postpartum visit. So if they didn't have a early postpartum visit, then the screening was not done for a questionnaire. So again, you can kind of see we have that darker area towards the left side. So we are bringing a higher percentage of our patients with these symptoms since delivery in for an early postpartum visit within 3 weeks. Next slide. So this table is basically condensing our risks, so our biomedical risk, interpartum complications, and symptoms since delivery screenings into whether there was at least one positive risk factor screened or they had none screened for, and then looking at this by the early postpartum visit. So the colors correspond to what the risk screening was. So purple is the prenatal biomedical risk screening, blue hospital interpartum complications, and so on. You can see we do have a large percentage of people who had at least one risk factor having that early postpartum visit, and then also just having some sort of postpartum visit. I think that's something that we've looked at our sites of, not only have we increased attendance to early postpartum visits, but we've also increased attendance to our birthing people at least coming in for one postpartum visit. Next slide. So we can also break down some of this information by our demographics. So this is, we get the question a lot with our network of, you know, why are we collecting demographics? Why is this important? This is one of the reasons why collecting demographics is very helpful for us, is we can break it down, break our data down by these demographics and really look at, you know, how are we doing across the board? Are there disparities at our sites with specific demographics and positive risks or needing or missing information? So this is looking at our feeding method. Blue is when it was screened at the hospital discharge, and green is during the early postpartum visit. So you can kind of see the first section is patients who identified as white, second is Black, and then Hispanic. For these tables, outside of our white, Black, and Hispanic race and ethnicity, we combined our other race and ethnicities into an other category because they have such a small screening number in order to better look at this. We still do have the ability to split that out. So if your site has a large population, Asian population, and would be interested in looking at that, we can do that. But for simplicity with these tables and to not have everything be too cluttered, this is how we chose to look at it in our report. Next slide. So this is looking at the early postpartum visit by insurance. So our first section is the medical assistance, and then private insurance, self-pay, unknown, and missing. So you can see out of the three at the top, our self-pay has a larger percentage of not having any postpartum visit. And again, we don't have right now on here any statistical significance, but this is stuff that we can look at to really parse it out even more. Next slide. So again, this is looking at the postpartum visits, but instead of insurance, we're looking at it by race and ethnicity. So you can see white, Black, Hispanic, and other, and then our missing. One thing we notice about our missing is a lot of times when we're missing demographic information, we also are either missing screening information or not having a postpartum visit. Next slide. Yep. So this is taking those risks and complications that we talked about on the other slide, broken down by there's at least one risk screened during that screening. So purple is prenatal biomedical risks, blue and hospital interpartum complications, and then the greens are the well checks for symptom since delivery, interpartum complications, and biomedical risks. And this is broken down by insurance. So you can look at the breakdown of those who screen positive for at least one risk factor in that screening and what type of insurance status they had. Next slide. And then this is a similar thing, but instead of insurance status, this is looking at it by race and ethnicity. I think that may be the last slide. Yep. So if you want to just go back, so I know that was not in depth on the data, but kind of a high level overview and an example of some of the data we're collecting, what we can do with the data, what we can look at. It is not to the degree that Mike will be able to present it, but I do want to open up the conversation if anyone has any questions about any of the data that you saw. Please feel free to ask. Or if Mike has anything that he would like to add.
I still think, you know, we're getting a sense of the prevalence of the things that we're asking about in our particular practices and across our network. You know, there are some things, you know, epilepsy, chronic kidney disease, DVTs, you know, very important, but rare. You know, maybe we shouldn't lose sight of those things now at this point in all of this. But I do think that probably this sort of, calculating some type of a score, like a risk score, if you have, 2 or more of these things or whatever, just like a lot of other things that we do in medicine, it isn't just one diagnosis, but it's sort of, the underlying risk, multiple comorbidities or complex interactions of, a respiratory disease with a cardiovascular condition going into pregnancy who end up having a C-section or something like that, where, we could probably see a lot of these things. And I think the real, impact of this evaluating like this and being able to look at your practice this way is to really say, how do we address and how do we dedicate resources to the highest risk patients? And those are not necessarily our MFM patients. They're the primary care risks that we absolutely know that those are the drivers for maternal morbidity and mortality: substance use, mental health disorders, violence, chronic medical conditions. And so we're identifying those here. I just think that there's so much that we're going to be able to sort of pick and pull apart here by combining biomedical and psychosocial, or biomedical risks or psychosocial risks. I just don't know how to, we don't have a validated scoring, thing that we can do, at this point in time. But it's just really amazing to present it this way and to see it this way.
Thanks, Mario. I noticed, there was a question in there and Mario answered it about some of the not seeing certain things. So again, this was just a high level overview. I wanted to give an example of what we could look at. This is not all of our questions. If you are interested in seeing what all of our questions are, I'm happy to provide them, but we do have questions on the method of delivery planned and then what actually happened. We have our smoking vaping question, history of current intimate partner violence, mood and substance use disorder questions. So there are more questions and more data. If you're interested in looking at all of that, we're happy to provide that. And some of that additional data may be shown during the webinar. But again, this is just kind of a high-level overview of some of the things we've looked at the most so far. And when we're presenting, residents are using this data to present at conferences or working on publications.
Mario, I pasted in the chat an example. There are actually diagrams in our report that kind of get into what you were talking about, just the combinations of some of these. So the one I pasted in the chat is an example from biomedical risks from the well check or the postpartum visit. And so it basically shows you all of those combinations where somebody might have hypertension and something else as an example. So that would at least give you a map to say, hey, which ones of these are truly rare in isolation, or they're rare, but they're often in combination with other things, which may then, like you said, increase the level of risk because there's a multiplicative effect there or something like that. So.
Thank you, Mike. Any other questions? Any questions around things you would like to see additional for the webinar? You can definitely think about that. You can put that in the chat, but just out of what we've kind of gone over, and then, if you're more familiar with our questionnaires or want to look at our questionnaires and then see specific data on that, please reach out. And again, continue to ask questions in the chat and we will answer them. So next section will be our trauma-informed care, which part of this comes around our adverse birth experience question in our 4th trimester questionnaire. We had a lot of discussion around this question, how best to ask it, and also the importance of the patients experience of adverse birth experience compared to the provider perception. So Stacy will be discussing this.
Great, thank you. Just to reintroduce myself, I am a family medicine physician. I'm faculty here at the University of Pittsburgh. So this may be review for some folks, but I think it's always good to have some space to talk about these things together with like-minded folks, especially since we are incorporating this into our next phase of our fourth trimester questionnaires. So we will get started. So the three things that I want to talk about here are with regard to adverse birth experiences. What are they? Why do we ask about them? And how do we have that conversation? So a lot of this content is pulled from the ACOG practice bulletin, caring for patients who have experienced trauma. This is the link, committee opinion, I should say. This is linked to that as well if you'd like to take a peek. It was back in April of 2021. So we'll start with their recommendations and conclusions. This is, we'll use obstetrician gynecologists. We'll sort of scratch that in our brains and just say people who provide pregnancy care. So they said it's important for us to recognize the prevalence and the effect of trauma and to be able to incorporate approaches that are trauma informed. And that part of that is becoming familiar with the trauma informed model of care. In an effort to create a safe physical and emotional environment for our patients and our staff, we want to implement universal screening for trauma currently and a history of trauma. And this last bit is relevant to a lot of us because we are in academic practices, but just a reminder that the benefit of the trainee experience has to be balanced with the potential negative effect of patients who may be re-traumatized by repeated exams or questions. Okay. So up to 45% of birthing people report a negative childbirth experience. And I think an important thing for us to keep in mind is that experience is subjective. So just because we wouldn't necessarily say there's a medical complication or it's not in the chart as a medical complication, it doesn't fall into what we would conceive of as a medical complication, does not mean that there was not a negative experience. That for the person who experienced it may have still felt that there was a negative experience. And I also want to make sure we understand that a negative experience does not mean that patients or family or whoever is sad that they had a baby. It does not mean a negative birth experience does not equate to I'm sad that this thing happened at all, that I didn't want to have this baby or something like that. Just means there's something about the experience of the birthing that was something they would prefer to have gone differently. Obstetric violence is a term that some folks might be familiar with. ACOG says it is a non-medical term that refers to situations in which a pregnant or postpartum individual experiences disrespect, indignity, or abuse from practitioners themselves or from the system. And it can lead to a loss of autonomy or be a result of a loss of autonomy. So some examples of that: repeated vaginal examinations, episiotomies when they're not necessary, overly restrictive labor conditions imposed on our patients, cesarean delivery that is felt to be sort of compelled and forced, and then more subtle manifestations. So telling patients that their symptoms they're having are not that big of a deal, and then certainly having any kind of differential treatment that's based on any kind of category. So religion, sexual orientation, gender identity, substance use, race. Wanted to call your attention to this article. I think it was really, I found it very informative. It's PTSD and obstetric violence. It was published in the European Institute of Perinatal Mental Health's journal. I think it was really a useful thing to help frame our discussions with our learners and, and with our colleagues as well. You're fine, Carolyn, you can go. So one of the things that was pulled out of that is some of these effects of trauma that we know exist. So we know that the effects of trauma on the brain and the body are real. There are neurobehavioral, social, emotional, cognitive changes. Experiencing trauma puts folks at higher risk for unhealthy behaviors as well. So things like substance use, self-harm, eating disorders. And there's a huge range of mental health conditions that can be experienced by people who have been exposed to trauma. And people who have had trauma also have higher risk of a bunch of chronic diseases. So big implications for the health of our patients. And then there are some specific OB-related trauma effects, chronic pelvic pain, STIs, unintended pregnancy, obviously having lots of feelings around pregnancy, sexuality, examinations, providers, all of that, and some difficulty with infant attachment as well. So why are we asking this question as part of our new and improved fourth trimester screening? 3 reasons. I think one is validation, just to be able to have patients have the validation that their experience was in fact traumatic for them. It was a negative birth experience. It was an adverse birth experience, and that what they're feeling is valid. Secondly, to be able to do something with that information, to be able to adjust the birth plan so that we are able to hopefully minimize re-traumatization. We're hopefully able to get a real sense of what patients are, what things went well and what things didn't go well, so that we can incorporate those or hopefully eliminate the ones that were not helpful. And then also as a way to refer patients to resources, which we'll talk about at the end here. Okay. So just so we're all on the same page, we're going to talk about the principles of trauma-informed care and then the skills of trauma-informed care. So the principles can be, fun little, they're not mnemonics, but, ways to remember. So 4 R's of the principles and 4 C's for the skills. So the 4 R's are realizing the widespread impact of trauma. That's partially what we're doing today. Recognizing those signs and symptoms. Responding, so doing something about that once we know about it and can recognize it. And that's integrating that knowledge that we now know in developing policies and procedures and changing our practice to be more trauma-informed, and then always trying to actively resist re-traumatization. And then our skills of trauma-informed care, these are the 4 C's. So the first C is calm. So making sure that you're paying attention to how you're feeling, how the patient's feeling, and try to do what you can to remain calm when you're talking to a patient and they're disclosing their trauma, or you're helping them, work through that. And try to create a space that's calming for the patient as well. The second C is for contain, which has a couple different meanings. One is that you are only asking the level of detail that you need to take care of this patient best, while maintaining the boundary to try to protect their safety, both emotional and physical. So you're really containing the deep dive to what you really need and what you think is going to be helpful and what they want to share. And then respecting the time frame as well. So if you know you only have 5 minutes to talk to this patient, probably not the time for you to have that discussion about their experience with trauma. And then being able to keep those things in mind will let you then be able to say, okay, this is the right place for you. This is what I think could be a good place for you, in terms of the next step for us to move forward in the sort of care for this history of trauma. Care is the next C. So self-care, compassion for both you and the mother, birthing person, or whoever you're talking to in this space about their trauma. And then cope. So leaving any encounter with a sense of hope and a sense of emphasis on patient and provider, or patient's resiliency and their own strengths, and then trying to make sure you maintain that for yourself as well, because doing this type of work can be difficult. Okay, so I'll open it up a little bit. Do folks have examples of trauma-informed practices that they use or that they teach, either on L&D, in the office, and maybe not even specifically with OB patients, but just trauma-informed practices that they know of or that they use? Feel free to come off mute or put it in the chat. Anybody have anything that they do or that they try to do in their either their conversations or their exam or their office structure or any of that? Yeah. Okay. Because we got the post lunch slot here, so I guess shouldn't be talking that no one has anything, but maybe that's good. Okay, wonderful. Thank you so much. Yes, love it. So allowing patients to do things themselves. If there's a way to have a patient maintain that autonomy and that control for an exam, like a self swab, that is wonderful. It's a great question. All right, well, I'm glad we're doing this then, because it sounds like maybe some folks are not familiar with what this might look like. So some examples would be permission before you're doing any kind of contact, before you're talking to anyone, before you're touching anyone, before you're touching anywhere at any point, asking permission. Providing descriptions of what you're doing, so not just kind of going ahead and doing an exam or a procedure and not asking. I personally ask if people would like to have everything explained to them. Some people don't want you to say every single step. That causes more anxiety. So I tend to ask first, but giving them that option. And then let's see, yes, allowing clothing to be shifted. So not saying take off all of your clothes, just kind of moving clothes as you need them to access different parts of the body. And then saying that you'll halt the exam at any time when when a patient might feel like they want to stop the exam, which I think kind of perhaps is similar to what Brianna put in Brianna put in the chat about a code word on L&D that folks can say if they are starting to feel uncomfortable. Thank you. So this is one little quote from that last article that I thought was helpful. It's true trauma-informed care empowers individuals by recognizing the significance of the power differentials and historical diminishing of voice and choice in past coercive exchanges. Therefore, at every opportunity, patients should be offered the choice to be actively involved in all decision-making regarding their care. Wonderful. Okay, so at your OSCEs for your new residents, you talk about doing trauma-informed care. Wonderful. That's great. This is from the American Family Physician, so the AFP's journal, and this was back in 2017, but I think the principles still apply, so we'll just kind of run through a couple of those. These are specific actions that we can do as physicians. So starting with the pre-visit, reviewing the chart before so that you don't ask things that are in the chart already that could be re-traumatizing. In that encounter, making sure you're sitting, asking your residents, med students, whoever else is in the room to also be seated, at least sort of eye level or below to your patient. Making sure that patients have the option to be interviewed alone, or if they want to have other people with them, making sure they have that option as well. Giving your confidentiality statement, running through what they can expect with the encounter, talking about why you're asking questions that might be sensitive, like substance use or sexual history, and then ask if there's a preference, if you're able to do that, if there's a preference for an interpreter, for the status of an interpreter that the patient would prefer, and try to get the interpreter who matches that. For the exam, asking if there are specific parts of the exam that patients might feel anxious about, and if there's anything that you can do to make them feel more comfortable, anything that past providers have done that was helpful or harmful, can also be a good question. And then, as we said, shifting clothing instead of asking patients to shift clothing instead of asking them to take something off completely, or you doing it. So saying, are you able to move this? Move your shirt out of the way. And then permission, always permission. So for those invasive exams, as we talked about before, if there's an alternative that is gives the patient more of the autonomy and power back, using that. Asking if there'd like to be another support person, describing everything setting up everything, getting consent before you have the person undress. And that's a struggle in my office, I will say, because our nurses are like, all right, you're here for an IUD, take everything off, you know? So being able to say, no, I'm going to go ahead and talk to them before I'm going to do the consent. I'm going to talk through the process. We'll set everything up, and then I will step out and have them change. And then language is, I assume this is something that you probably talk about in your OSCEs, Caroline, about language to use during these exams. And then part of that language is talking about what things might feel like. So what sensations the patient might experience. Having a signal we talked about, speculum self-insertion, similar to the self-swabs. And then making sure you have the supplies ready so that patients are not sitting in stirrups while you're getting whatever comes next. I'll make sure you have that at hand. Then lastly, giving some guidance about imaging. So if you're sending someone for an MRI, it's going to feel really tight in there, and it's going to be loud and, you know, all those things. Transvaginal ultrasounds are not the same as a transabdominal ultrasound. Making sure that people are aware of that lead aprons can feel like there's pressure on top of you. If there is a trauma history that would be relevant, notifying referrals so that they are aware as well and can try to avoid re-traumatization. And post-visit, so getting written aftercare instructions and follow-up plans, because even folks without trauma can be very distracted, can be confused, overwhelmed in a medical visit. But folks who've experienced trauma can certainly have dissociation or anxiety during a visit. So making sure we're doing high quality aftercare instructions that are written, and then using language that is sensitive for those diagnoses that might go in an after visit summary, because that can also be a source of violence or abuse if folks are able to see that, or just re-traumatization for the patient themselves. Okay, so this is the question that we have in our new version of our 4TM questionnaire. It is, did you experience any physical or emotional distress during or after a prior childbirth that you would like your care team to know about? And if yes, then you would follow this up, obviously, with the discussion with the provider. There's space for providers to write. You can go ahead. Okay, so any thoughts about some important elements of that conversation? Has anybody who's doing 4TM right now had this conversation and had found some ways that are helpful, or things that were hard that came up when asking this question? Or if you haven't used it yet, can imagine some things that might be helpful or would be less helpful in this conversation.
I think there'll probably be plenty of things we don't realize are traumatizing that come up in it that we think are normal, or trying to be sensitive. That
Totally agree. Absolutely. Well, I will tell you what some of the literature says about the ways that we should have this conversation. And if anyone has anything that comes up, please feel free to add to this. This is a little bit old, but I think it was still useful. Unfortunately, there's not a ton of the literature is not chock full of people doing studies on how to talk about birth trauma, I will say. So the few that exist, I'm going to highlight a couple of those here. This is from the British Journal of Midwifery a few years ago. So a few things that were pulled from this study: prompting the woman to tell her own story, listening with encouragement, but not interruption. So trying to give as much space as possible and asking those open-ended questions. encouraging expressions of feelings, doing that active listening, reflecting back. These are things that, again, we probably are teaching learners in their motivational interviewing and that kind of thing. Those things can be helpful here as well. And then seeing if there's any connection between what they're describing to you about their past trauma and their current feelings, emotions, or behaviors, or worries, or anxieties. Or is there a connection between that trauma and what they're experiencing now? Making sure that we are acknowledging and validating grief and loss, especially if it's something that we maybe wouldn't have thought, to Caroline's point, that we wouldn't have thought would be something that was perceived as a loss, or that someone is grieving, to make sure that we're acknowledging that and validating that. And then the one time that we want to kind of like interrupt and counter is when there is this expression of this thinking of self-blame and inadequacy, and that there's something wrong with what the patient themselves did. This is another study in sexual health, pregnancy, and childbirth. And the things that I thought were relevant from this are the focus of trauma discussion it's really not about, let me make sure I have every detail of the trauma that this person experienced, and when it happened, and who did it, and what time it was, and all of that. The really important part is to figure out enough that you can help that person get to resources, support, change your practice to help them not be re-traumatized, and to help them heal. So definitely focus not on the specifics as much as the patient wants to tell you. It's really on how did that impact your life at the time? How is it impacting your life now? And what can we do to make sure that impact of it is minimized as much as we are able to. It's important that we're forewarning our patients about this discussion. So, the questions that we are asking in these questionnaires are, could be considered sensitive in general, but this is probably the most sensitive one. So making sure that we are saying that that's something that whatever your typical IPV kind of screening is in your protocol or in your offices would probably be sufficient, but making sure that you're forewarning folks about this discussion before you do, and that you're emphasizing the confidentiality part, and that they don't have to answer your questions if they don't want to. And then just recognizing that partner presence can be a barrier, even if we're not necessarily talking about interpersonal violence, even if we're not thinking, oh, well, yes, the partner should be gone, because what if they're perpetrating violence? I think in this discussion, it's also important to have it without a partner, because some mothers birthing people may have experienced something as trauma or as loss that they don't feel comfortable sharing with their partner. Maybe their partner was somehow involved in their invalidation of their feelings, or in that trauma around their birth experience and delivery. So I think even though we're not necessarily asking about interpersonal violence, still important to have this conversation at some point without the partner in the room. Okay, and then wrapping up here with some resources. So things that have been shown to be helpful in this: support groups, journaling, individual therapy. And then I wanted to point out the National Maternal Mental Health Hotline that's fairly new, but I think 2 years old now, from HRSA as well, that folks can call, and it's specifically for maternal mental health, separate from the general mental health one. And then second to last thing, this is from March of Dimes, and the March of Dimes has a whole sort of initiative about writing your story as a path to healing from birth trauma. And so if you think patients might be interested in that, this is something that they offer, and they offer a place to share it if they'd like to, anonymously, but publicly, if that would be helpful. And then the thing I wanted to draw your attention to is at the bottom, where it says thought starters. So these are meant for people to be able to jumpstart their writing of their story, of their birth story. But I think they can be helpful if in our discussion too, if someone says, well, yeah, maybe, I don't know, some discussion questions that you could kind of prompt them with, like, how did you feel when you got pregnant? What happened right after your delivery? Did you have the baby? Did the baby come to you right after? Who were your supports when you were in the hospital? Things that might help a patient who maybe hasn't fully, conceptualized their experience yet, get to a place where they can kind of work through it a little bit with you, and then perhaps work with other settings as well, and other resources like Micah just mentioned. Okay, this is actually the last thing I think. This is I wanted to point out the Preeclampsia Foundation, who also has a really fantastic resource list for birth trauma. So if you find that this is something that you are ready to implement with if you're going to start implementing fourth trimester, or when we start, asking this question, I think it's not a bad idea to take a peek at this website just to familiarize yourself with some of the resources, and then you can decide if it makes sense to share with your clinic or with your residents, or post somewhere, or do it at Didactics or something. But I thought it was actually one of the best resource lists that I found. Any questions, thoughts?
I have a lot of thoughts. I just will take a minute and to say thank you, Stacy. I think that there's a lot of things that we've done as a network that are much deeper than just the data and the medical topics that we cover, like implicit bias or reproductive justice. And this is one of them. And I think we're all trying to figure out how to address this. Is not a thing that we've been fully trained to do, and we don't have practice in doing it, and we're all trying to get better. But I think that this, as a network, that this should be something where we continue to come to get more information, resources, and be able to share with one another, so that we could sort of, disseminate that in our sites, more readily, and sort of leapfrog, and not all have to do the same thing. Start from scratch every time, for us and our practice and our institutions and our learners. So this is not going to be the first time I think that we cover this topic, and I think it's a really important one. But also, when I think about the implicit fourth trimester model, this sort of screening that we do in the third trimester to prepare for the fourth trimester, a lot of that is just a little bit of things that we should be doing anyway. Like, we should probably know if our patients, like, their BMI, and if they had a prior postpartum hemorrhage or preeclampsia or those types of things. Like, we should probably know those things. That's sort of the status quo. But what we're trying to do is to better prepare for the fourth trimester and the postpartum experience by having sort of some knowledge of the key things that matter in the pregnancy in that third trimester. And this is, I think, the one of the things that really jumps out as being the most important, because you illuminated a few ways in which we can actually change the birth experience. We can alter it based on what we know about a patient's prior experience. And that's very different than just knowing if they have gestational hypertension or if they've had a history of a hemorrhage or something like that. There's very non-patient centered things that we do to improve care in that way. But this is one that I think can be very significant. And it's not one that I think we're not having that conversation with patients now, largely. The sort of the outpatient to inpatient sort of divide that happens, even if we are having those conversations, I'm not sure that it's really translating into, different practices I think that patients can see or appreciate. So, just to me, this seems almost the most important part of at least that part of the fourth trimester, is really getting this right. And yet it is also going to be the most uncomfortable.
Yeah, I agree. I mean, I think half of our patients, that's a huge number, and that's who are reporting this is true, right? So if we think about the like the data that we looked at, the prevalence of some of these other things are tiny, right, compared to that. And so I think it's something, one, because it's so prevalent, and also, as you said, because we actually can make a difference. Not that we can't make a difference in, preeclampsia, but like we have a lot of power, and residents could feel empowered to make a difference in that too. I think sometimes they don't feel like they can really do much about some of these prior comorbidities. So thank you. Laura? Yeah.
I know in our practice, we actually hold a debrief with the patients after delivery to try to minimize birth trauma so that they understand at the moment what maybe didn't go quite right, or things that they perceived were something done to them or something that was unexpected for them. And so I think debriefing with our patients after delivery may help to minimize some of the birth trauma that would carry forward.
That's a great point. I wonder if, I'm just throwing this out here, but Anna, Carolyn, I wonder if we should maybe do something about like a session about sharing what people do in their practice. I don't know. I always think it's so interesting to hear what people are doing. And I think that's part of the reason why it's so wonderful to be part of a network that we can do that. So I wonder if it would be worth sharing what people are doing around this.
Yeah, absolutely. I think that's also part of our fourth trimester webinar coming up, is we do have 3 sites that will be represented to share what they're doing. But I agree with you, having more of that dialogue, and that helps other sites that are interested in implementing, figure out different ways of implementation that may work for their site.
Thank you.
Thank you so much, Stacy, for that presentation. And thank you guys, everyone, for participating. It was really good to hear all feedback. Anna, did you have something?
Yeah, just real quick before we move on, I just wanted to, for the 4th trimester, we are actually in the process of doing a qualitative study right now, where we have 3 of our health systems that have implemented 4th trimester. We are doing we have concluded the interviews with birthing people who recently gave birth, and are in the process of coding, and then we'll be analyzing this data. We will be planning a presentation later on to look at it, but I think this is something that's really important as a network. We're really trying to be cognizant of is most of our questionnaires and processes are being developed by providers or healthcare professionals, and that we're missing the patient voice, and really wanting to, especially with 4th trimester, and understanding that there's such a difference between the patient experience and the provider interpretation. So really wanting to bring that patient voice in, and how can we do better screenings? How can we provide better resources? So I think that's something we've been very intentional about, and would like to continue doing as we continue 4th trimester, and also doing it with ICC as well, to really get a better understanding of how our screenings are being interpreted, and are we missing out on anything? And I think the great thing with the 4th trimester project is different to ICC is we have these screening questionnaires, but we don't have specific interventions. And we really want sites to implement the screening into their standard workflows, and utilize resources that they have to help with the risks that are screen positive, but just really identifying how can we better help our patients. So I think that's something that, as a network, we're very much looking towards in the future, is wanting to include more patient voices and community resources. But yes, thank you very much, Stacy.
Awesome, thank you. So we are going to go into our kind of final updates, wrapping things up. Looks like we'll probably be ending a little bit earlier than 2:30, which is great. So I'm just going to go through a couple last minute things. If anyone has any last minute questions or thoughts, feel free to put them in the chat or share. And like we've said, that this will be available after our meeting. So we'll have recording and we'll have the slides for everyone to review on their own pace. We're just going through some committee updates. Scholarly activity, currently working on 3 publications at the moment. Their end date is to be, like, there's no clear yet. We're not really sure when everything is going to be published or out there, but there are 3 articles in motion. We're going to have our 4th trimester webinar on April 30th at 5:30. So that is also kind of part of the scholarly activity. It's a great space for people to share questions or insights on how things are going. Our data review meeting has been supporting scholarly activity in the publications, creating and updating network documents for grant writing. That's kind of also scholarly activity and data review are doing a lot of intersectional things, supporting 4th trimester updates in the phase 2 rollout. So now that we have those 4th trimester question updates, just supporting our sites and keeping track of how many sites have updated their EHR systems with these questions, how many sites are collecting data. And the data review committee still meets on the 2nd Tuesday of every month at 5:30 to 6:30 p.m. If you would like that specific link, or if you have lost it, please let us know and we can forward it back out. Health equity, we're working on connecting sites with community resources. So kind of Scott's presentation this morning aligns with some of the efforts we've been working on in encouraging sites to develop more community connections, and then also trying to understand where we can help our sites make those connections, knowing that there's limited resources available sometimes. And we're also just looking for our next project. I am currently the lead of health equity and scholarly activity. So when I step down, I think our new project coordinator will be taking over some of them. So it's also kind of a nice stage of revamp. If health equity committee wants to go in a different direction or anything, it's a great time to start new fresh projects, because there'll be a new face and new fresh eyes on that. Okay, so 4th trimester webinar, April 30th, 5:30 to 6:30. Please let us know if you have any questions. That is a shareable link. You are able to forward that, so please feel free to forward it to other members on your site, other team members on your sites who are doing 4th trimester. If you have any reasons you're unable to forward it, please let us know and we can send it out to others as well. And then our fall meeting, it's going to be Thursday, September 19th. So fall meeting is going to be in Philadelphia in person. We co-align with FMEC because there has been some things changing with the way FMEC is going to be hosting their conference. It's just going to be one day, and it'll be that 19th, 7:30 a.m. till 12 p.m. Eastern time. We'll have office hour times in the afternoon, so that will be just space for people to, our coordinators and other team members will be available to answer the questions, work through any issues if that morning meeting was not enough to work through everything. Are there any questions?
And I did want to open the floor to any questions about anything we've covered today, or if there's something we haven't covered. I know we had a couple questions in our registration form that some people asked. If you don't feel comfortable asking them here, we will be following up with you about those questions. But please, we are going to be ending early, and since you are already here, it's a great time to ask some questions, especially since there are other people from other sites who may have experienced similar things or have advice. Rebecca?
Yes, for those who are using Epic, are you able to collect your data directly from Epic?
I can take a stab there. There are reports that you can run, through Epic where you could run those reports yourself, and you can get sort of essentially a spreadsheet of information. Our build is not set up to do that. Those are, the fields are not the ones that are sort of, those fields. But our build, for instance, in Epic, they're built with smart data elements that can be reported out. We rely on an analyst to build a report and then run that report automatically at a certain interval, like every month or every 2 months or something like that. And so the data gets spit out of Epic, but not in a way where we can run a report and look at, our patient panel or the most recent A1C or blood pressure or things like that other people might be able to do. I'm not sure that anybody has set up ICC to be able to run an Epic report on their own. I don't know if Amy's still on.
Yes, I'm still on. What was the question?
Can you get your own data out of Epic in an Epic report, or does it have to be a like a slicer dicer type of report, or
Oh, you're getting fancy now. I have a workbench report for it.
right, but so you can do a workbench report?
Yes. I
Okay,
typically I'm typically horrible at being timely in it, so I usually use Crystal because you can do larger loads that way. But yeah, all of it is available as a workbench report. I tend to use the workbench reports more when I'm doing CQI projects on site rather than exporting it to share with the rest of the network.
So Rebecca, it sounds like there's a lot of different options, but most people have it set up. The build is relatively straightforward enough that it should be, the data can be pulled out of Epic one way or the other, not a manual review.
Okay, so our site actually has developed a prenatal registry that pulls from Epic.
Mhm.
So we follow our prenatal patients and postpartum patients in that way. If anyone would be interested in that code, we're happy to share it.
That would
I think that would
lovely.
be
I have our fourth trimester set up the same way.
Uh-huh.
But I'm always interested to see how other people implement it and what ways we can improve it.
Great.
Yes, and I agree. I think, that's been a challenge for some of our sites implementing fourth trimester, is really how to design that patient registry, and each site is a little bit different. So the more kind of information and different resources we can glean from other sites, I think the more helpful that will be for moving forward and helping each site. I will say, as far as data pulling from Epic, most of our sites with ICC have it pretty standardized and have some reports. We have multiple sites that don't have Epic, and we have some sites that are fully manual. So it really varies. I will say for fourth trimester, we are still in the process, and the data requirements and getting data out is a little bit more cumbersome right now. But our goal is to get it to the same point as ICC of being able to create reports to run, to pull that data and get it into REDCap. Any other questions? Any other final thoughts about anything? Kim? Oh, no worries. I did want to just take a moment to thank Carolyn for all of her work that she has done with the network. She's been an invaluable member and will be greatly missed. I appreciate everything that you have done, and many do not know this, but she has fully implemented ICC and is working on fourth trimester at all UPMC family medicine sites, which is an amazing feat. And just everything she's brought to the table with data and scholarly work, really appreciate it all, and will be sad for her leaving, but are wishing her the best for her journey. I'll be lucky enough that she's coming towards my neck of the woods, so I'll still be able to see her hopefully. But thank you very much, Carolyn, for everything that you've done.
Thank you, Anna. That's very sweet. I appreciate it.
And then we did just get a question in the chat that I wanted to make sure that we have asked. So our site is still considered emerging and we have not yet shared data with the network. We have next gen, so not Epic. What's the process of beginning to share data and who would be the best contact person regarding this? So I would say if you want to reach out to myself, and we would work most likely with Mike to, get any pointers or tips, and also with Amy. But we do have some sites that have implemented in other non-Epic EHRs. And we can see, if we have any additional sites that are using NextGen as well. So I would say first step would just reach out to myself, and I can work with you on that process.
Thanks so much. Yeah, I'll do that. We have a person from NextGen who's willing to work with us on drawing the data, and we'll talk about how to make the connection. Thanks.
Absolutely. I would say having a person within the IT EHR world that's willing to help is a humongous step, and super helpful. But like Amy said, I think, with the Epic build is, while it may not be the exact same, she does have resources that kind of parse it out and show smart data elements, and what exactly we are collecting. So that can be really helpful too. Anything else?
I just also want to thank Carolyn for investing 2 years of her career with the Implicit Network. The creativity and energy that this team brings to push us forward is more than we can do by ourselves in our clinical lives, and just really appreciative for all the work that the team has done. And then this is really, we have a work plan that's designed to be spread over 4 staff. Right now we have 2 of them currently doing all of the things, and Anna has done the thing that she's done for the last couple of years, which is to be an excellent at all things and to step into the project manager, network manager role in Maha's absence, to help get things set in so many different fronts as we've expanded geographically and topically with new projects and new sites, and to prepare for this meeting. I just can't say enough wonderful things about your leadership and the value that you mean to this network. So thank you, Anna.
Thanks, Mario.
And they got the meeting done on time, and we're finishing early, so even better. More kudos. And I'd like to say thanks also to our Department of Health support in Pennsylvania. I don't know if Shanna is still here with us today, but they are with us every step of the way, to continue to support the work that we're doing and amplify it, and help to find ways that we can continue to grow and sustain our network. And so very thankful for what they've done for the work that we've done in Pennsylvania, and really all of Implicit.
Thank you very much. So just as a reminder, we have a webinar coming up on the 30th. That invitation has been sent out. If you have not received it, please reach out to myself and we'll make sure you get it. Again, share it with whoever you think may be interested. We will be sending out a save the date for the fall meeting shortly. So be on the lookout for that. And we will also be sending out, likely next week, a post-spring meeting kind of quick survey that just helps us with preparing for future meetings and making sure that we're presenting topics and information that is important and meaningful to you all. So thank you very much, everyone, for all that you do for the Implicit Network. We really appreciate you taking the time to be with us today, and we hope you have a wonderful rest of your day.
Good day, everyone. Bye.